All right, so this is a super interesting case. Before I hit start on the recording, I just want to give you an overview of the case. It's going to be a upper case where we're treating the right side and the left side in a little bit different manner. The right side, we just have some old failing restorations and some misshapen teeth, and we want to do a midline shift. So on the upper right, we're going to be doing removal of decay and prepping the teeth for veneer/crown lays. You'll see that the preps are a little bit aggressive because we need to change the shapes of the teeth and the dimensions of the teeth. Specifically because on the left-hand side, we're going to be expanding her smile, and her left-hand side has a failing bridge where she's missing tooth number 10 and tooth number 13. Very interesting how we sequence the case so that we're able to impress everything all at once. So here we go. So you can see here, we're going ahead and getting her numb. We start to remove all the failing amalgams. We're doing the upper right side first. She's wearing an isolite to allow me to do this pretty quickly. And we use a big fat diamond burr to go ahead and start to prep. And we try to prep as little as possible on the palatal of these teeth to keep the integrity of the teeth. But on the buccal and the occlusal, we're a little bit more aggressive so that we have good retention of our restorations and, more importantly, enough space to build the ceramic and still get the strength. Her final restorations are going to be made out of a core of zirconia with feldspathic porcelain on top of that. We're having great success because we can mill the margins really, really thin and get great marginal adaptability. All right, so here we go. We go ahead and we're prepping everything. Any cusps that are not supported, we are reducing. But again, most importantly, we try not to prep the palatal unless we have to or it was prepped before. And here we go. We're up to the lateral right now. Finding the preps, breaking the contacts. Yes, you can go a little bit more conservative on these preps, but I really like going into approximately because I get better bond of my zirconia, and more importantly, I have to do a midline shift here, and you can see how the shapes of the teeth, we need to share them in between each of them. So there's quite a lot of change that is going to be happening in these cases. All right, we check our reduction with our wax up. We see in areas where we're hitting a little bit, we start to cut a little bit more. Make sure that we have the double plane reduction so we have no undercuts and we have enough reduction at the incisal position, which is usually the position where people have problems. You can see in their temps, they usually don't reduce enough at the incisal position. And because I'm doing everything in zirconia, I can do the feather-edged margins and not have to worry about anything chipping. Just finalizing the margins here a little bit better. And now we are ready to go to the left side where we're going to cut off this bridge, which was really collapsed inside. So we're going to be expanding her smile. The real fun part of this case, stay till the end, is the way we treat the lateral. I wanted to do whatever I possibly can to save that central incisor. I had already a root canal treated, but it had a very, very, very thin buccal plate. So I was going to do whatever I can to make sure that I saved that tooth. There was no gold in this bridge. It was not flexing at all. So we really had to make our slice through and then pop it off. You can see there's decay around that canine. It's over-prepped. I'm going to try and fix that as best as I possibly can. Try and remove the over-taper, remove the decay, deepen the margins. Finalize the preps on all the other teeth. And you can see right now there's not a lot of bleeding, which is a good thing for us at this point because we're going to want to do our final impression before we start doing the surgical part of this procedure. And that means the implants and the grafting. So we're finalizing the temp, and now we're going to prepare for a little bit better post, or a post that wasn't there at all. We use a metallic post in this case. Dry up the canal as best as we can. Self-etch, bonding agent, dry, cure the top, use a veneer tip, cure the inside. Cement it, rotate it, and get some good retention on the post. More bonding agent. And we're going to head and rebuild this tooth after curing it with PermaFlow from Ultradent as best as I possibly can. We go ahead and prep, obviously, because the post is pretty large. You'll see some of the post is going to be showing through after I finish the prep. At the end of the video, I rebuild it with a little bit more composite to make sure that the metal is not showing through. There was a crack there in the tooth, so I had to go after the crack to make sure that it wasn't all the way down into the root. Thank God it wasn't. It was just superficial. And then I'll rebuild part of the tooth at the end. Make sure the crack is clean. Finalize the margin. Rebuild a little bit more. I love Vertice Flow. Self-etch composite. Finalize my prep. Not the best in the world, but good enough for now. Laser to make sure that everything is exactly where it needs to be. Because at this point, before we're going to elevate the flap, we're actually going to take the final impression. All right, after we took the final impression, we are densing that implant position. We're doing it flaplessly. And we'll go ahead and placing our implant. We put our scan body on. We go to the scan body window and we scan that. All right, we're putting healing abutment, and now we go after this. This had a massive, massive, massive horizontal defect. We're gonna do a papilla sparing incision. I didn't want to go too wide to create too much scarring. But she's starting to feel a little bit on the palatal. Release, release, release as best as I possibly can. It was nice and tough. When there's a huge defect, it's not the easiest thing to open that piece of tissue. So we open, open, open. And as you can see, there's a huge defect there. So I go and I very slowly drill with a pilot drill. It's about 1.5, 1.8. This is a 2.0 Densa in reverse. I'm expanding the bone as best as I can. I'm still in bone. I didn't perf or anything like that. And then I go ahead and I place a 3.3 implant. This is over 80 Newton centimeters of torque. Check my angulation. Go to the head of the implant. And finalize the placement. Perfect. And now we go to work. And although we didn't have a perforation, I would think that my bone is maybe 1 millimeter, maybe less. We go ahead and we place the desk abutment because I have a feeling I'm going to need an angled tie base for my screw retained crown. I go ahead and I scan that. And now all my impression is done. I go ahead and place a nice healing abutment to hold up to my tissue. And I start to release the tissue so that in a case where we do potential normal grafting, we want to make sure that we close with as little tension as possible. Cortical cancellous mix. And we start to pack and pack and pack. And although it's a very small space, you can't tell from this video, but the defect is massive. Now, it's not enough to be able to do this. We go ahead and we take what's called a laminar bone plate, which is my alternative of using a mesh. And this really holds up the graft and almost sometimes even creates its new cortical plate. Once that's in place, through the graft, through the flap, we suture everything down. This is 5/0 nylon. I want to make sure this does not disappear too quickly. And you can see that it's there with no tension because I released really well down inside, not by making the vertical releasing longer, but by really releasing the attachments deep down into the periosteum up high. That releases the flap, and most importantly on the sides is extremely important to do. So I make sure that that part of my flap is not moving. The tissue is very frail in this area. Untangle myself. Very nice. And now we go to, I think it's 6/0 or 7/0 Vicryl for the corners. You also can appreciate that when I make my incision, my scalpel is always at an angle, so that when I put everything together, they sort of slide right on top of each other. Like they call it the bevel, internal bevel that we do when we do the incision. And you'll see when I finish suturing this side, you'll see how the left side just comes right together, almost not even needing sutures, but I did it anyhow. In this case, I did it continuous. Hold everything together. And then close. And you can see that side of the incision on the left is basically completely closed because of the way that we made our incision. It's slid one right on top of the other, so we should get minimal to no scarring in that area. And we close nicely, make sure all the ends are short, trim them up. Dry everything up, everything looks good, dry some water, make sure nothing's flying out. Put some Vaseline on the teeth. Well, actually put Vaseline only on the core, and then slight bonding agent, a lot of air, cure for like 5 seconds. And then we have our putty matrix. I always make that line. Go ahead with Luxatemp fluorescent bleach. Let it set. And as it sets, we start to take away all of the excess. If you, your lab, or your assistants made you a good putty, when you take this off, you should have little to no contouring on the buckle needed. We wait a full 5 minutes so that shrink wraps itself onto it. And that's it. Came out perfectly. We're just going to go ahead and trim the palatal portion of it. Thank God we got no bubbles on the buckle. We made enough reduction where we need to be. We're going to clean up the palatal. And I try to do this as quickly as possible because the patient is still numb and she's not going to be feeling any of this, and you can clean it up real nice. And when you open the contacts, these temps, they basically get locked in. So you need to make sure that you have to contour as little as possible. Clean up the areas all by the gum line. Polish where you need to polish. Little alcohol on top to remove any of the oxygen inhibition layer. Glaze everything up. Add a little bit of blue for some translucency. And a little white to frame it out. And now she heals. And that's really how we were able to go through this case and be able to scan it and have no issues. I hope you enjoyed it. Comment below.